I think it's a tooth where it's probably a modern disease of our own cause. I think I disagree on that one. I think the patients that wear their teeth, they're able to load their teeth quite hard, much harder than I'm able to do. I have an anterior open bite and the class 3. I've never been able to touch my front teeth. I don't wear my back teeth. I think I am not able to generate a type of forces that wears my teeth. But I think most patients who wear their teeth, they're usually in full occlusion. I think having posterior wear is more a function of consequence of how they function, how they chew, how they eat, how they swallow, how they process food when they take food into the mouth.
So whether you use it or not, I'm sure we've all heard about the Dahl technique, right? This is when you have localized anterior tooth wear. And what you're doing in this case is you're building up the anterior teeth even though you don't have space. And so because you're building these teeth up, when the patient bites together, now they are prematurely hitting their front teeth. The back teeth are all open. There are like bilateral posterior open bites. And what happens over time is intrusion of the anteriors and over eruption or dental-alveolar compensation of the posteriors, and the occlusion, like magic, reestablishes. So if you want to go deep dive into that, check out our previous episodes on the Dahl technique. Like these are some of the ones we did 5 years ago with Tiff Qureshi, and they are literally like Protrusive Hall of Fame. So do check out those and I'll link them at the bottom. But today's episode, my friends, is on something quite different. It is same, but different, as they say in Asia, right? It is the reverse Dahl technique, i.e. now, instead of having localized anterior tooth wear, we have localized posterior tooth wear. Think of that patient who, when they bite together, their posterior teeth are just shot, right? There is exposed dentine, there is lots of erosion, and so you've got plenty of localized posterior wear. And then the premolars, canines, and anteriors are maybe a little bit worn, but not that worn. And the problem we have is that, yes, the posteriors are worn, but when the patient bites together, the back teeth are all contacting, meaning you don't have space. So with the reverse Dahl technique, or modified Dahl technique, what you do then is you build up the posteriors in composite, you leave the anteriors out of the bite, and then like magic, the posteriors will intrude and everything else over-erupts, if you like, and the contacts will reestablish. Now, our guest today, Dr. Kristian Ognedal from Norway, does a wonderful job of discussing this technique and his experiences, and at the end, he shares a case. So for those of you who are listening while you're jogging, on a train, while you're driving, don't worry, I describe the case and the exact scenario. But those of you who are watching on Protrusive Guidance or on YouTube, you'll actually get to see the images as well if you listen all the way to the end. I was quite excited to record this episode because it's a new one, right? It's a new thing for me. I haven't seen much published on the interweb about this technique, so hopefully you'll learn something new. Talking of learning something new, every PDP episode, I give you a protrusive dental pearl. Now, as you know, I'm a family man. And for those of you on our community, Protrusive Guidance, I'm always talking about the books that I'm reading, or actually I'm listening to on Audible. And the current one, I just feel compelled to talk about it. It's called Hold On To Your Kids. Like, I've got two boys, a 6-year-old and almost 2-year-old, and I think a lot about being a dad and being hopefully a good dad. I actually always wanted to be a parent. I actually love my role as a dad. It's my favorite title in the whole wide world. Quite often I'll pick parenthood books or relationship books, because just like I'm interested in dentistry and I read the dental literature, I'm interested in parenting and being the best parent I can be, so I kind of am attracted to these kind of titles. Now, the book again is called Hold On To Your Kid. It's by Dr. Gordon Neufeld and Dr. Gabor Mate. And it essentially talks about how in modern society, children lose the attachment to their parents too soon. And so what it talks about is that what children of modern societies do is when they lose that attachment to their parent, they then gain the attachment from their peers. And then it's like, the blind following the blind. And there's a major cause of anxiety and disconnection from family. I'm actually now just getting into the really good parts of the book where it's actually telling me solutions, right? The whole first few hours are talking about the problem, right? The problem of losing attachment to your children and how you cannot serve two masters. So they can't be attached to their peers and attached to you as their parent at the same time. They have to pick one. And the way that we have the schooling system, the way that we have social media and phones, that they're constantly now messaging each other and they're gaining their attachment from their peers, no longer from their parents. Now, we need that parent attachment for them to have a healthy emotional development and emotional security. So I'm listening in now to all the strategies we can use as parents to literally hold on to your kids and hopefully watch them grow into kind and courteous and emotionally healthy adults. So I just want to talk about this book and I want to share it with you, right? That's my pearl for today. I know it's not very clinical, but I like to talk about what's important to me. And right now, what's important to me is parenthood. And I know so many of you are in the same boat as me. So check it out. Hold on to your kids. It is quite heavy. It's like one of those books, like, you know that book, Why We Sleep? Like, you can just summarize that entire book in one sentence, which is like, sleep is really important, right? So the vibe here is that parent attachment is very important, way more important than peer attachment. And so hold on to your kids, but really it's the strategies that it gives you. So I'm just getting to the good bits now. And if you're interested in this, do check it out. I'll put the link in the show notes. Now, let's now join Hans for the full episode. I'll catch you in the outro. Dr. Hans Kristian Ognedal, welcome to the Protrusive Guidance podcast. It was so nice just a few months ago now, I think, to spend some time together in Bergen. And I was really amazed by this presentation that you gave, talking about this technique that we're going to talk about today. You know, Hans, I didn't tell you this, right? But this podcast right now, it almost didn't happen, right? If you asked me 20 minutes ago if this podcast is happening, I would have said to you no, okay? Because we were having a Lego incident, okay? We couldn't find a Lego.
You couldn't find a Lego. Oh yeah, the kids were going to bed and the Lego was missing.
New Batman robot Lego that we built yesterday, right? And literally that we turned the house upside down, and obviously I was getting the blame. The missus was blaming me. And then anyway, she had tidied it away somewhere, and she won't admit it, but she found it. And I'm so glad that we get to talk about it, and this episode gets to happen tonight because you're such a busy guy, man. And so I'm glad. I'm really appreciative of the fact you made time for this today. Please, can you tell us about yourself, Hans?
My name is Hans, easy way. I really enjoy dentistry. I'm not a specialist, but I'm specially interested in dentistry. It's my hobby, it's my work. I enjoy every part of dentistry. I enjoy talking with colleagues. I enjoy treating different cases of all kinds. I love composites, I love ceramics, I love surgeries. And the lecture you heard was about treating worn teeth. And lately that's what I'm talking quite a bit about, and it's also a problem that's rising, and you see more and more of tooth wear, and so it's definitely a challenge that has come into modern dentistry.
Tell the listeners where in the world you are speaking from today, just so I want them to get a bit more context.
I'm speaking from I'm just assuming that you know I'm speaking from Stavanger, Norway. It's in the southwestern part of Norway. Right now we are in March and we don't have snow at the moment, but it's just turned cold again, so who knows what's going to happen. It's generally a lot of weather on this side of the Northern Sea. It's
and
more mellow
over dinner, you showed me some images, family images of the weekend, going skiing and stuff. I mean, that was really cool to see. And you know, you're a family man, but you're a really great dentist, very well-rounded. And you know, the amount of wear you're treating, I think we have so much to learn and unpick with you today, Hans. I think I want to start with just a quick review. I know I have episodes on this already, but can you just, for our younger colleagues, just recap the original Dahl principle that we kind of use today when we're doing the anterior teeth? Because we're talking about the opposite today, but just recap the anteriors.
Yeah, to recap, the original Dahl's concept was about creating occlusal space for anterior crowns. And so they made from cobalt steel plate that they either cemented or just attached to the front teeth, and then the patient walked around chewing on those, and over time would create occlusal space for making anterior crowns. But Dahl has evolved over time, and now that we have direct composites, most Dahl cases are made with anterior composites. You build them up palatally, and then teeth intrude or erupt and into full occlusion over time. So that's the original Dahl concept with a modern take on it.
And in Scandinavia and in the UK, we really embraced it. I feel like we are the pioneers. I mean, obviously Scandinavia, but then UK is really very popular treatment here. Whereas my dear friends in the States, they're almost very skeptical about this. And what is your take on this, international friction to adopt it?
I think there are quite a few myths concerning occlusion. They're kind of scary. So when I was a young dentist, we didn't learn very much about occlusion, which is perhaps why I do what I do, because I didn't know enough occlusion, or didn't believe enough in occlusion to let that hinder me. I think it's a problem with breaking myths. It takes a long time to adjust to new information and all new information trickling down, and especially on the Dahl concept, which was a thing in the 60s and 70s. There hasn't been much research on it after that. And it's also a fairly cheap technique. There's no one willing to invest in it and invest in doing the research on it, because if you do it right, it's really, really cheap, and you can't make money of it as a company. So I think it's somewhat forgotten and somewhat lost in strong opinions on occlusion that you can find around the world, if that's fair to say.
That's a really good point about a lack of interest from companies and the trade in this technique, because it's the way it is, right? And therefore, that could be a fuel in the fact that it's not been pushed about as much as it could. Now, what we're talking about today is a different way of doing Dahl. Now, I like to call this the reverse Dahl technique, but what's the difference between the reverse Dahl and the modified Dahl? When you say that, do you mean the same thing, or what do you mean?
Yeah, I think we mean the same thing. I was able to have a conversation with Reyes Syed recently on the Dahl technique and what he's doing, and I told him what I was doing. And yeah, I think it's the same thing. It's just I chose to use the word modified because I don't think it's really reverse.
I like the name. I think it's cool, like opposite Dahl technique, reverse Dahl technique. But yeah, I see it. Okay, so guys, when we say modified or reverse, we mean the same thing.
Because a reverse Dahl to me would mean that you grind teeth down to let them over-erupt. That would be the opposite of doing good. Well, the opposite of what you want to achieve.
Exactly. Now, we know there's the direct composite splint technique, which I did have the authors of that paper on the show 2 years ago. We know when you have a cracked molar and you actually bond composite to make it in supra-occlusion, and then the composite will stop the cusp from flexing at the same time, because that's the only tooth in occlusion that's going to intrude. Then when you take off the composite, you now have occlusal space. Is this something that you did first, or you entered into, or you started to, or I guess, share your journey about how you first got into this? Was it from anterior Dahl to then posterior, a modified way? Tell us more about that.
Well, I started like everyone else doing the anterior Dahl, and then I started to struggle with what you do when you wear your molars. And in the beginning, I did what I was taught. I was taught to do gold onlays. You can make them really thin, so you don't grind away too much tooth. Or if the tooth was damaged in other ways, you could do a crown. So that's without touching the vertical dimension. So that's where I started. And then I thought, okay, this is going to be really expensive for the patient, or some patient couldn't afford doing a treatment that way.
So when in those scenarios we have posterior only wear, the way you would manage it traditionally at the beginning was gold posteriorly to rebuild the structure or protect the integrity of those posterior teeth, right? Now, when you were doing that, you were still conforming, or were you opening the vertical dimension on the gold?
No, I was still conforming, trying not to open the video. If I would combine that with doing something anteriorly, because I was really afraid of opening the vertical dimension.
Despite doing the anterior Dahl stuff? Because for me, early on in my career when I started doing Dahl, that was a massive help in losing that fear. Right? When you start doing Dahl and you do a lot of it, you're like, hang on a minute, my patients aren't dying, their condyles aren't popping out, maybe we're okay.
Yep. Yeah, like I said, this is really early, so this is maybe 17, 18, 20 years ago, so because I'm not a young man anymore. But then it kind of progressed. I started covering exposed dentin. I thought, well, at least I'm going to buy this patient maybe a year or two, and it's really easy to do just flowable composite. And when I referred patient to orthodontists to have work done, not particularly wear patients, but they were putting on, oh, we need to elevate the bite, we'll put on like 3 millimeters on this tooth, this one tooth. And the patients didn't seem to complain about it. And I thought, well, maybe I should try putting on a little bit more. And then I knew that if you want composites to last, you need 1.5 millimeters. I thought, well, let's try that one. Let's try putting on 1.5 millimeters.
So kind of like you apply the bite turbos in the orthodontic world to this setting. It's interesting. Kushal Gadia, a restorative consultant, once taught me years and years ago, and I love this because sometimes patients tolerate big changes in occlusion better than the tiny changes. And that was like a really funny thing to learn, actually. And I think it holds true.
Yeah, I think there's some truth to that. If you're off by 1/10 of a millimeter, that might be quite painful for the patient. But if you build it up 2 millimeters, that doesn't seem to pose a problem. Patients usually tell me that it feels a bit weird the first week or so, and then it feels fine. They're not bothered by it. There might not be an occlusion at that time, but they're not bothered by it anymore. And some people just forget that they've had it done, or they just function normally through the day, and when you see them next time, they're almost in full occlusion. So I have done that. I have done that on single teeth. I have done that on just a few teeth. But usually when I do posterior build-ups of that high, it's part of a full case where you do multiple build-ups.
Okay, well, let's move on to that then. Let's imagine a case of localized posterior wear, right? So we got anteriors that typically look pristine, right? Maybe they have their mamelons, got the incisor halo. They usually have good-looking anteriors, but the posteriors are worn into dentine. I think it's important to discuss the etiology of wear in these patients. What have you found was the causative factor in these patients, that pattern of wear?
The pattern of wear. I'm not sure if I have a part in my lecture where I talk about the pattern of wear. And usually I divide the cause of wear. I'll have to go back to what's erosion, what's attrition, what's abrasion. And I find that in most cases, there are some acids involved. There's some erosive component involved in wear. And if you want to see that, okay, there's most likely an erosive component, where's that acid coming from? Is it internally or is it externally? So having a chat with your patient, having the patient make a chart of their diet for a week, for instance, and then you can go through that with your patient and try to pick out stuff, and you can see, because you can't really tell if the acid's from the external or internal from the pattern of wear, because I think the pattern of wear is probably due to the way the patient chews, how the tongue covers the teeth, how the cheek covers the teeth. So you can't really say, is this internal, is this external? So if I can't find anything in the diet that can cause that type of erosive wear, of course we'll have to look at, do you have some type of reflux? Is it, you might not have symptoms on reflux, but you might still have reflux. I'm not sure if you know the term silent reflux, and I apologize for my English. It's
Oh, dude, you should hear my Norwegian. It's not very good. No, dude, honestly, you're doing great. But the silent reflux, quite classically, people say that you have like this, like this, like a little cough that's kind of is pathognomonic of this.
Yeah, but you have to kind of tease it out in the conversation, because they haven't really thought about it. And they say, well, I haven't really thought about it. And then you see them in a couple of weeks or a month later, and they come back and say, well, yeah, actually, I feel some of the things that you're talking about.
So at that stage, from you, is it before you do the treatment, is it referral to the GP, or how do you make sure that before you start treatment, you fix it?
Referral to the GP, sometimes referral to gastro.
Mm-hmm.
There are some new guidelines in gastro in Norway, so now they start treating on suspicion. Instead, if you're under 50 years old and they suspect that you have some gastric reflux problems, they start just treating with antacids right away. So because they think that swallowing a camera and doing pH measurements is way too invasive and takes too long and costs the society too much money. So much easier to get a packet of tablets and try it out.
It's like you may not be treating the root cause, you're just kind of medicating the issue, but that's a whole different topic. As long as the acid is not destroying the teeth, I guess, but ideally in a utopian society it'd be different.
If you are discussing the root cause, I think the modern diet is underlying most of these ailments. So diet is underlying gastric reflux, obesity, and also tooth wear, because we live in a world where all food you can get hyper palatable food that is really scrumptious to eat, sometimes very high calorie, sometimes no calories, high in acids.
And zero nutrition.
And I think it's tooth wear. It's probably a modern disease of our own cause. Whereas in the past, like if you see I went to the London Museum and saw the old Egyptians and took pictures of their teeth, and they were eating grains with sand in it, and of course they bore their teeth. But now we know better, but now we've caused our own problems by having the food industry working.
Just to add to that, Professor Bartlett, when I was his DCT trainee, probably the worst training he'd ever had, but he taught me one thing, which was when you have the purely attritive patient, the patient who's like, a severe grinder, and you can imagine the tooth contact time for that individual during the day and night could be high in an imagined scenario, but even that patient will not wear away their teeth that much, because ultimately enamel and enamel is like two similar, aka identical materials rubbing on each other, the wear is not that extreme compared to, let's say, rough porcelain against enamel. The enamel will take a hammering, right? So actually, when you put a 1 drop of lemon in the equation, you see a serious escalation. So I'm glad you started with that actually acid erosion is a huge player. And when we see these worn teeth, don't ever just think, oh, this grinding is bruxism. In 99.99999% of the time, there will be acid erosion, and that'll probably be the primary player.
I completely agree. I have some bruxists in my practice. They are usually, there's some psychiatry involved in bruxism. At least with the patient I see, they have maybe a tic, like they're tapping the teeth or grinding the teeth, and those cases are of course really problematic to solve. And of course it's also psychiatry, which means there's less income, there's all sorts of problems regarding those patients. And of course my composite doesn't last as long, but you can redo them. That's the beauty of this technique that we're going to talk about, is that you could just redo it. You can sandblast it and you can put on some extra.
As Tiff Qureshi, who does so much for Dahl and making Dahl accessible to dentists around the world, and what an absolute legend he is, I love his term, recycling the Dahl. 5 years, 10 years later, recycle. Oh, my patient's on her second recycling of the Dahl, right? And it's just amazing what you can do, exactly how you explained. Just final up on the etiology. So why do patients present with localized posterior wear? Acid erosion, a huge player. And please correct me if I'm wrong, because I feel as though you have a lot more experience in looking into these localized wear cases. I feel as though these patients may have started with an anterior open bite type of occlusion, whereby they already had a heavier posterior occlusion, and then when you put the acid to compound on that, it's like the opposite to the deep bite patient. Think of the anterior deep bite patient, where they destroy the anteriors more and the posteriors are spared. It's like the reverse situation, where you've got the class 3 or the AOB, the posteriors are just get more chewing time, more contact time, and then when you throw acid into that, by the time the posteriors have then worn down, the anteriors now are getting in contact. This is just my theory, and this is what do you think about this?
I think I disagree on that one. I think the patients that wear their teeth, they're able to load their teeth quite hard, much harder than I'm able to do. I have an anterior open bite and the class 3. I've never been able to touch my front teeth. I don't wear my back teeth. I think I am not able to generate a type of forces that wears my teeth. I do have jaw pain though. On the opposite side, you have the patients who never have jaw pain in the muscles, and they are usually in full occlusion. They have a really heavy bite on, and they load all their teeth because they need all their teeth to support that amount of force. I have this one patient who he managed to intrude his teeth. So he had a full arch bridge on 11 teeth, and he managed to intrude that bridge into his gums. So that's an outlier, of course, but I think most patients who wear their teeth, they're usually in full occlusion. I think having posterior wear is more a function of consequence of how they function, how they chew, how they eat, how they swallow, how they process food when they take food into the mouth. I think that's probably more important, because I don't think none of these patients, I think to have a anterior open bite, that usually means patient with anterior open bite usually have a large maxillomandibular angle. They have usually like a long face like I do, usually more crowding. If you have a tongue thrust, you're biting on your tongue, which kind of stops you from biting too fast. So the anterior open bite cases, those are actually the cases where I don't recommend doing a modified Dahl or reverse Dahl. If they wear their teeth, they wear their cusp, the molar cusp, they wear them flat because that's the way they function horizontally. But when they're worn flat, it stops. If you don't put acid in there, or significant amounts of acid, even with exposed dentin, that wear just stops. When the cusps are ground down and the patient functions in laterusion, then it stops in those patients.
No, definitely. When I observe that, you find that the molars are very flattened, but they stay like that when you see them year after year, and you can do a time lapse and see how they progress, and they stay very stable.
Yeah, I definitely do recommend taking photographs. Following your patient with wear is always beneficial to have a long-term relationship with your patient. So usually if you could at least observe them for a year or so, that would be nice. If they're in pain, if you have to do something, you have to shy away from that rule and treat them, of course. But if you can, spend some time with them, have a checkup or two, take some photographs, and sometimes information pops up that's really interesting to know.
It's important to have those conversations and plant those seeds.
Oh boy, but I place a lot of blame on diet, but of course there's some environmental causes as well. So if you work in industries like smelting, there's sulfuric acid in the air. If you work in a swimming hall,
the chlorinated water,
with highly chlorinated water,
yes.
that also may cause erosive wear. If you're a farmer, you're using methyl acid. What's that? That's in English?
Don't know.
Don't know. It's you use it to preserve grass in dairy. Okay. That will also be in the air while you're working with it. So I've seen a few farmers having worn their teeth, and I think it's probably due to that, because they couldn't find anything in the diet, couldn't find anything on reflux, so possibly environmental for them. So it's a good thing to know your patient and have a conversation. You'll learn surprising stuff once in a while.
So that's where the occupation history and the social history definitely comes into play in these erosive cases. That's 100% for sure. In these cases, Hans, have you noticed a pattern of types of occlusion? So do you find that you're seeing more class 2 people, class 1, class 3 people? Like any traits that you see? People with shorter faces, stronger muscles, any traits that you see?
Yes, definitely. So in the literature, it's called brachyfacial patients, with the square-faced patient. Those are definitely on the wear list of patient who wears their teeth. You can also see the kind of in the middle, the mesofacial patient, and then you got the long face patient where you don't see much wear, but usually you see more TMJ issues. So definitely it's the mesofacial, the squarish faced patient, and really, well, you can usually see, I usually take pictures of my patient's face from the front and from the side. And that's quite informative sometimes. I
think that's important for anyone who perhaps doesn't do that. Sometimes when I was younger, I was only taking photos of the teeth and I was missing that information. And I think the more you appreciate the face and the role of that and the muscles, it's definitely a great idea to start taking that facial photo as well. Let's imagine that example case that we've imagined, the posterior localized wear. And we've said that, okay, this patient has probably a brachyfacial face, strong muscles, silent reflux, and they've managed to see their GP, and let's say they've controlled it, and now you're looking to treat and plan this case. Because this patient's young, the primary reason to treat here is not aesthetics, it's far from it. It's to preserve their teeth, to make sure that they will keep their teeth for as long as possible, right?
Preserve the teeth, but ultimately also to preserve aesthetics and functioning, because if you lose your molars, it will inevitably hurt your front teeth over time.
Your patients complain of sensitivity?
Yeah, then usually I do an impression just to have a model so I can have a look at the model. And the way I do the reverse Dahl or modified Dahl, it's a direct technique. So after I've assessed the models and I've checked the curve of SPE and checked if are there any interferences for the teeth to either erupt or intrude, and we'll have to have a chat about eruption and intrusion after this one. Then I build up to, usually when you're worn down to the dentin, you've worn about 2 millimeters off the molar cusps, because young molars and young healthy molars, they have about 2 millimeters of enamel on top of the cusps. So you know, if you add back anatomy and use anatomy as your guide, you will add about approximately the right amount of composite to the top of that tooth for the composite to be fairly wear resistant, to not break.
The first question I have there, Hans, is it makes sense to use anatomical norms, because that will give you not only the right form and function, but also actually gives you the right amount of thickness for your composite anyway, which is like what you said right at the beginning. But just to go back one step, we got to talk about it, right? Joint position, right? In these cases, are you using centric relation as your guide or not? How are you recording the joint position before you wax it up on the articulator?
Like I said, my occlusal education was very poor, so I usually start from MIP, from full maximum intercuspidation. And since after I build this up, the patient rarely hits more than maybe 1 point on each tooth, maybe on the 7th. So I try to kind of divide the forces between 3-7 and 4-7, for instance. And you're hitting just 2 points. It's really, really, really easy just to make sure the patient hit those 2 points about the same time, just for comfort. But otherwise, the occlusion will evolve from there. So the occlusion will evolve from there. So what I'm thinking is that joint position in these cases doesn't really matter, because you're working in a system where everything changes. I think we as dentists, and I think this is part of why occlusion has become such a difficulty, is that we're thinking of our mouth and our teeth as static, because they are firm, there's no cells that change the surface, they're not like the rest of the body. But the truth is, teeth are living, teeth are moving, and they are in place because of all the functional forces that are on them. Their tongue, lips, cheek, chewing forces, habitual forces are keeping teeth in their place. And so we're working in a system that changes all the time. I don't really think it matters. What I do think matters is that when you cover that sensitive dentin, the patient will be happy for it and will be able to chew after that, and will be able to have a glass of wine and some shrimps and a shrimp salad sandwich without being in pain, which is from day one after doing that treatment.
Okay, well, in this case, I love the idea of the second molars, equal intensity contacts. But in a typical case that you've treated, is it just the second molars that are getting the composite, or are you having to do the second molars, the first molars, and the second premolars? But actually, because you've built them up to anatomical form, it's actually only the second molars, because the way the jaw closes, that are taking the contact. That will then intrude, and then the first molars and the premolars will eventually come into contact. Just explain that. Hello, YouTube Protruserati. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and it's built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually, for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive Guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
That is completely correct way to put it. Just because of the function of the jaw, how the jaw functions, you will only be hitting your most posterior teeth when you're doing those build-ups. But of course, I take the opportunity to build up the rest of the teeth that are worn, but the patient will of course only hit on the most posterior teeth.
And in this case, would you typically just do, like, obviously I'm sure you're looking at the anatomy of the teeth and you're thinking, well, both the upper and the lower are destroyed, so let me add in wax on both, or like split the difference? Or do you tend to have a strategy to preferentially wax up one arch more than the other? Or what have you found? Or is one arch more affected than the other usually?
I usually don't do wax ups. To me, this is a direct technique for different reasons, but I've been practicing my anatomy for a long time. It feels really easy for me.
So it's a freehand technique?
It's a freehand technique.
That's so cool.
So you don't need to use technicians or use wax ups. Those techniques are for the really, really difficult cases where you don't have much anatomy to guide you. So if the teeth are completely destroyed, maybe you lost a third of the occlusal height, completely exposed dentin, then it becomes a lot more difficult to do those build-ups because you don't have any reference points. I find that my technique, I was lucky to be able to see one of Didier Dietschy's lectures on interceptive dentistry, and he does that directly in the mouth, and this technique resembles a lot his technique, but he's of course much more fluent in occlusion than I am, so he takes that into concern, but he says the problem is how to get enough space for the most posterior teeth. On this technique, the reverse Dahl, the modified Dahl, that's the answer to that question. You let the teeth move, so you build up. So yes, you build up all the teeth that needs to build up.
Yeah, so upper as well as lower, basically.
If there's wears on the upper, yes, I treat those as well. Perhaps not at the same time. Perhaps we'll do the lower first, and then we'll wait a few months before we do the uppers, just to make the patient a little bit more comfortable. But I have treated patient who wanted to have it all done in one go, and of course they ended up maybe with a 6mm anterior opening afterwards. But yeah, it worked out. But usually I have patients that are close by, so we can stage the treatment a little bit more and perhaps make it a little bit more comfortable. Although I haven't had any patients really complain about discomfort.
Well, we're going to unpack about, when you monitor these patients, how long it takes and whatnot. We're going to get to that. But just one little thing which I find amusing is that if I was doing this treatment, like if I'm building up the lowers, I would be looking at the upper. And if I'm seeing like a really sharp cusp, I'd be smoothing it down. Do you adopt to that as well to try and get nicer forces?
If you have a really sharp cut, I know about your concept of Robin Hood dentistry, but in this case we can do more Oprah Winfrey dentistry. So you can get a filling and you can get a filling. And so if you have a really plunging cusp in the upper and you have a kind of the U shape, you have composites or amalgams, uppers and lowers, and they kind of worn U-shaped. Yeah, then I would probably just build up all teeth during a short period. Then you'll be able to lower the cuspal planes, so that you get the cuspal plane won't be as steep anymore, and you can build the cuspal planes so that they're less steep than the canine planes, and that takes away a lot of those problems. So the patient get more freedom in lateration in horizontal movements, and you transfer guidance to the anterior or the canines.
Okay, so let's talk about that. You've just done, let's say, the lower second molars and the first molar and the second premolar. When you deliver this, the contacts equal intensity only on the second molars because the way the jaw closes.
Yep.
But at that moment in time, do they still have some canine guidance?
Well, it depends on how deep your bite is. So if patients with really deep bite, usually they have, when you open them 1.5 millimeters posteriorly, they still can touch with their front teeth. They can still bite off food with their front teeth. So some patients are like that. Some patients have less, where you open them up. They don't have any contact on their front teeth. Doesn't seem to matter much. Both groups of patients, in my experience, doesn't really experience much
Are you having to adjust the excursions in any way to make sure they're to a particular liking?
So that's what you do on the follow-ups, because after doing a full jaw build-ups, at least I'm really tired. So I'll just make sure that they're hitting those 2 points, and you've made cusps. So cusps will have some planes to them, so sometimes you have to adjust for excursions on the cusp. And sometimes you can use cusps to kind of guide teeth into the right position. If you have a pronounced curve or spee, for instance, in an older patient, you get most of the tooth movement, I believe, is in the lower jaw. You get intrusion in the lower jaw, and that can open contacts, and then you can use the cuspal planes to kind of guide those teeth and close those contacts over time.
But the day they leave you, when you fit them, obviously we're tired and stuff, but when they grind left and right, it's not only the dots on the second molars, but they're also grinding on these second molars, right? But that's okay. That's how you leave them.
Yeah, I'll just leave them like that. But sometimes, of course, it's composite. You can adjust it. And like I said, you're also in a working environment where everything changes. So what might be completely fine on the day you leave them might not be fine when they come back after. Usually I see them after a month to do some adjustments. Hopefully we'll get to talk about how we do that. I do that. But yes, you can be mindful of excursions. Not too mindful though, because now you just built up those teeth and everything's changed for the patient. Nothing works the way it used to. The neurology isn't there. Reaction patterns aren't there. So that just needs to settle. The patient just needs a bit of time.
Okay. And the patient then goes away. What's your review schedule like for these patients? Like, how often do you see them? And then more importantly, what have you observed, Hans? When you're seeing them, they come back at week 1, they're like this. They come back at week 5. And I'd love to know what is an average of what you're seeing, and when do they fully establish contact?
Yes, I think we have to start talking about the curve of Spee in this case, because teeth have a constant width. They don't change the width unless you grind on them. So the curve, it works like a bridge, like the keystones in a bridge. So if you try to compress a curve, compress the teeth into the curve, for instance, for uppers, if you want to intrude uppers, that's really difficult because you're trying to compress those teeth into a curve. That means you might have to do some IPR between those teeth to have them intrude. And the same with the lowers, the curve of Spee. Usually if you have intrusion, then intrusion is easy. But if you want them in a younger patient, if you want them to erupt, that means you might have to release a little bit in between the teeth to give the teeth an opportunity to erupt into the curve. Other than that, sometimes you need the help of an orthodontist if you really don't want to grind on teeth, or there's no opportunity to grind on fillings or things. And sometimes you can just leave it like that and just be aware of that. It just takes a lot longer when the teeth have to move a little bit horizontally to adjust for that curve of Spee. So when the patient comes back in after a month, you usually see them after 1 month. They've been well informed about this being a little bit awkward in the beginning, and after a month they're well on the way. Usually they've closed more than half the way down after a month.
Do you think there's any condylar repositioning happening there? Do you think that very quick change, like in the anterior Dahl, we used to say that, if you see a lot of change happen very quickly, that's not necessarily intrusion and dentoalveolar compensation. That could be the condyl's repositioning. Have you suspected the same in your cases?
Yeah, why not? Why shouldn't that happen? Everything else changes. I think in terms of how fast a patient comes back in, a rule of thumb is that a tooth can move about 1 millimeter per month. So to me, it seems like that's approximately the rule that I follow. So that's why my take is that it's probably mostly intrusion for those patients. I check with my foil, I check with my contact paper, and also I use a floss. So I check the contacts with the floss. If they're really hard, that tells me something about how the teeth move. So if you have a really hard contact and it didn't used to be really hard, that means that, okay, if it's in the upper jaw, yes, this tooth is probably intruding. If it's in the lower jaw, then yes, this tooth is probably erupting. And you have to decide if you want to make some space for that. So that's what I do on normal checkups. But most of the time, patient is completely fine. Yeah, it was a bit awkward in the beginning, feels better and better. Then we do an evaluation. When should I see you again? Perhaps I see you in another month. Perhaps I see you in a couple of months. And sometimes patient close the occlusion really fast and they say, no, I can't be bothered by coming back. We'll see you at the next checkup. So, and then they do, and it's fine.
Well, a bit like the question I have in mind now is a bit like orthodontics. Like, I'm imagining at that first review that there will be some increased physiological mobility of those second molars, which is part of the process. A bit like ortho patients, aligner patients, when you take off the aligners, there's some mobility. And for a younger dentist who's never seen this before, that can be quite worrying. But just it's confirmed, have you observed that? And just to reassure everyone.
That happens. That definitely happens. And in one case, I built the posterior cuffs. I built them too steep. I was into pronounced anatomy at the time, and I of course had to adjust for excursions on those teeth, and they firmed up. For the next checkup, they were fixed again. So yes, be aware of teeth moving. Sometimes it's a good thing, sometimes it's a bad thing, and I'm not sure if me adjusting the occlusion on those teeth helped or contributed to the case, or was irrelevant to the case. It might have just solved it by itself without me intervening.
Good point. Good point. And in these cases, when you see them again and you follow them up, what percentage fully established contact, and then how long on average does that take? Does that take like a year, 2 years? Quicker on younger patients, longer on older patients, kind of thing?
No, I think it depends on how much force the patient is able to put on the teeth. Most people I treat for posterior wear are not young guys. They're older people. They're 35. 40, sometimes 50s, and the eruptive potential of the teeth is not really high. In Dahl's study, he said that his selection of patients, and that's one of the myths of Dahl, is that it's about 60% eruption and 40% intrusion. But that's the average of the selection of the cases that Dahl investigated. But he says in his article that it seems that eruption is more pronounced in younger patients and intrusion is more pronounced in older patients, and he related that to facial growth and facial changes as you age. So it kind of depends on the age of the patient. If you have an old patient, most of the changes will probably be intrusion. And if you have a very young patient, most of it will probably be eruption.
And at the end, once the teeth establish contact, are there any adjustments you need to do at that point, or do you find that everything just falls into place nicely and you don't need to do any adjustments?
Yeah, usually I don't need to do any adjustments, but I do think about occlusion when I do the build-ups. Like I said earlier, I prefer to make the cuspal planes less steep than the canine plane, so the patient usually ends up in anterior or canine disclusion, canine guidance. Do you need canine guidance to function? For most patients, probably not, but it's a way to possibly save my restorations a little bit longer, just to make them last a little bit longer, to not place them under tensile forces and try to make all the forces on the composite compressive.
Very true, and that's a huge tip right there, guys. What Han said, to try and keep your restorations under compression, because our materials can handle that much better. And so you mentioned the word longevity to make it all last longer. What do you tell your patients? And sometimes what we tell our patients is not what actually happens. We actually hopefully undersell it and over deliver. So how long does it take until Hans is going to recycle a posterior Dahl case?
I haven't had to recycle many of them so far. I've recycled a couple of them, and that was like 10 years and 12 years. So it lasts quite a long time. But then I have a couple of patients who crushed their composites. So the composite looks like gravel on top of their tooth. And then I said, okay, we need ceramics here. So sometimes that happens. But then you've created a space for the ceramic. So you can do the ceramic much more minimal and invasive. But I do think that ceramics does have apart from being quite expensive doing ceramics, I think they do have a place in the posterior Dahl, or the modified Dahl technique as well. And if you're really brave and think you know what you're doing, you might go directly to ceramics.
That was just what I was going to ask, basically. I mean, I'd only trust you to do that because I think you need a bit of experience when you're doing these kind of cases, I guess. But have you done that then? I would, with you, how many cases you've done? Have you done where you've just gone to ceramics, especially nowadays with I'm recording soon with Pascal Magnier on occlusal veneers, right? And 0.4 millimeter zirconia, occlusal veneers, or maybe some thicker lithium disilicate ones, so minimal prep because you already have the thickness, because you're opening the bite. There could be some benefit here.
But I'm thinking also that you've negated the problem of making, so you don't have to make really thin occlusal veneers. Yes, I've read about it and read some research on it, and it's quite a favorable prognosis, but you don't have to make 0.4 millimeter occlusal veneer. You can probably make them for a decent thickness that really make them last, because teeth will move. And perhaps you can do a temporary in composite, just a quick and dirty one, and then wait for occlusion to settle. And then you can do it in ceramics to give a very long-lasting restoration.
So in a few cases, you've had to do that because they're trying to destroy the composites. But in a lot of these cases, you're seeing them last, and you're probably just observing and monitoring.
Yeah, I think it depends on how much of the damage is caused by the patients by attrition, how much of the damage is caused by erosion. So how much is physical and how much is chemical. So I've seen patients that have followed up for a long time, and which they have mostly erosive wear, and then you see they undermine the restorations that I've done. So the restorations are still there, the enamel around it just kind of disappear, and then you have to go back. But then it's composite, so you can go back in and you can put the rubber dam on, and you can do some aerobrasion, and I love my AquaCare for that. Do some aerobrasion, and then you can just bond highly filled flowable or maybe normal paste composite and just repair those damages, and then you can go on for a long long time.
Brilliant. And just because we're wrapping up now, I'd love to see, Hans, if you're able to on the app or on YouTube, have you got maybe a before and after when the occlusion reestablished, just an example case to help the visuals?
Yeah, let's do that. I'll have
Okay, so while you're doing that, and you'll see the share button at the bottom. While you're doing that, I'm going to ask you, I'm going to be very naughty, and while you're focusing on finding a case, I'm still going to ask you some questions, okay? So you're going to have to multitask big time, okay? Contraindications. Are there any contraindications to this technique that you can present to, a very keen young colleague who might say, oh, I'm going to try this tomorrow. Can you put some shackles on them and suggest some contraindications?
Anterior open bites. Do not do this in anterior open bites. The diagnosis is the selection. The worn posterior teeth. Those patients, when you give them that diagnosis that they have tooth wear, posterior tooth wear, that's when you can do this type of treatment.
Kind of those tough cases where you're scratching your head thinking, how do I fix this? Because there's so much more wear posteriorly than there is anteriorly. And you're kind of like scratching your head, and then you think, yes, this technique exists.
Yeah, so you already selected your patient by having a patient having wear. So it's important that there is wear. And also, if you can stop the wear by getting the patient to change their habits, even exposed dentin will last a really, really, really long time without wear. So you might not need to do build-ups. And that's why I said you have to have a proper diagnosis. You have to know why is the damage, why is the patient looking like the patient does right now before you start doing any treatment. So that's my take on it. And also patients with TMJ. If you have TMJ, but then again, you normally don't have occlusal wear, avoid opening the bite on the posterior. It might be quite painful. So let's see if I can share an image with you from a case I've done. This is the posterior Dahl case.
So I'm just going to describe it for those audio listeners, right? So those on Spotify and Apple, some beautiful rubber dam dentistry going on here with the beautiful Teflon ligatures as well. And it's a classic erosive case with the wear. You see the cupping. I see some attrition as well on the second molar. So yeah, kind of like the scenario we described.
Yeah, so we aerobrate that, clean it up well, put in some separation between the teeth, and then start building up. I usually start a little bit on the marginal ridge, then cusp by cusp.
Your comps are beautiful, man.
Yeah, thanks.
Lovely anatomy.
These sessions are quite enjoyable for me. I love building that up. And this patient, you see, that's him right after. He has quite a deep bite.
So it's a deep bite patient.
A deep bite patient, but
with those crowns on the centrals, but rest of the teeth are unrestored.
Yep.
So probably a trauma case.
Yeah, a trauma case when he was quite young. Those crowns are made by a dentist in London, not by me. He was working there at the time. They're really nice crowns, in my opinion. So that's right after I've built those teeth up. You can see there's a little bit of marks on top of the cusp there. That's not really contacts, just abrasive mark from the occlusal paper. And these are pictures.
So a lovely shot here, clearly showing the posterior separation in the premolar region, right? So obviously anterior, we can't appreciate it because you have someone with like a complete 100% deep bite, and now they have like a 90% deep bite. Whereas on the premolars, you can see how they're out of the occlusion now because you've only treated here second molar and first molar and lower only.
Yeah, lower only on this guy, because we're staging the treatment on him, and like you said, he has a bit of a plunging cusps on the uppers, so perhaps I should have done the uppers at the same time, but I know he is local here, so I know I will have to treat him several times during his lifetime, at least my professional career, if he decides to stay with me. And this is about, I have to check my notes on this one. Sorry.
Mate, this makes me so happy. This is the money shot right here. This makes me so happy. So guys, we're seeing the photo, right, of the established occlusion, and it's just a thing of beauty here, right? Those premolar spaces have been filled in just in a marvelous way. And the intercuspation here, on the left especially, is really beautiful.
Yeah, he's really back to where he was before we began.
And he's got the 100% deep bite again, or maybe the 99% deep bite.
Yeah, he's back to having a deep bite. He will. I think, should you really do orthodontics to fix that deep bite? Perhaps. I don't know. He seems to work. It's
well. It's another option, right? You fix the deep bite and you create some space posteriorly, but then that's a very tricky case in terms of anchorage and stuff, right? Because you're trying to intrude the anteriors and intrude the posteriors, and so that's a very tricky overall case, I think.
I'm really happy to refer orthodontics to an orthodontist, so I'm not doing much of that myself. But that's 2 months after on this guy.
2 months, that's very impressive.
Yeah, so like I said, it depends on how much force the patient is putting on their teeth and how fast they can move them. And I think my The case that took the longest took about 3 years. I built her up. Then she got cancer, got really, really sick, hospitalized for a long time, and of course teeth didn't move. But when I saw her a year ago, she was back to being healthy and then in full occlusion. So something is happening. There are some muscles involved, I think. But she was comfortable all the time, even though her bite hadn't closed all the way. It just closed partially. She was comfortable. I said, okay, now that you are ill, should we just grind away some composite to make you more comfortable? And she said, no, it doesn't bother me at all. And when I saw her a year ago, she was back in full occlusion. So changing the occlusion doesn't really matter. And as you said on the lecture I saw you on, you shouldn't really be touching your teeth too much anyway during the day, during the 24 hours of the daytime. So
very true. And the only question I have now, because I know someone's going to mention in the comments, right, is they're going to say, and I think I know what you're going to say as well, they're going to ask you, do you give the patient a guard after they've established their occlusion?
Yes, sometimes. I've tried that. Generally, guards are not used for a long time. Perhaps maybe a month or two in the beginning. The patient is still thinking about it. Then they forget the guard when they go to their cabin or on holiday.
To my cabin.
Yeah.
Reminds you of
Yeah, that one was really good.
Performance.
Maybe to know what the fox says. So I think compliance on night guards to stop wear is poor. And I'm not always sure that it's the nighttime where that is the problem. Perhaps it's the daytime wear, and then they're not wearing a guard anyway. So I don't
Right, now,
do
I
guards.
just want to see what you're practicing.
I don't do guards. I said you should tell this will wear, and next time we'll add some composite again, and you'll wear that away again. I think that is more comfortable for the patient. But of course, you have some patients who are really, really conscientious and are able to wear a guard during nighttime every night and do that consistently over the years.
Hans, you would have seen in Didier Daichi's cases that he shows, right? He shows these like ridiculously brilliant 30-year follow-ups, right, of anterior resins. The thing he says, which is the same thing that Tony Rotondo said last year when I saw him speak and show his like 22-year-old recall, is the only reason this patient's composites look so good is not because I am a master, it's because she wore her night guard every night. And that's what he said in his words. So sometimes when you get that patient who really wants to keep things pristine, and if the nocturnal bruxism has been an etiological factor, then that can help longevity. But I completely take your view that it takes a special kind of person to be able to comply as good as those patients.
Yeah, like I said, it has to be nocturnal wear, and it has to be a really conscientious patient. They do exist, but how many patients, how many night guards do you need to make to treat that one patient who will actually use it?
Asymptomatic patients have got the poorest. Like if you've got symptoms, you've got TMD, and you're symptomatic, and then you're willing to wear even the most wackiest of splints. But when you give an asymptomatic individual an appliance, then you will definitely have to accept reduced compliance rates. We've crossed the hour. You are approaching midnight, but yes, and please, you're approaching midnight, so I want to make sure that you get to bed. But Hans,
I'm fine. I'm happy talking with you. I just wanted to make one last point.
Yes, please.
Patients that wear their teeth, they don't have TMJ problems, so they're asymptomatic in the first place. So that's a point to you that giving asymptomatic patients splints doesn't really work well unless they're very
absolutely.
And sometimes, if they're dentists, they might. If they're dentists, I do treat some dentists as well.
That's very true, actually. That's very true. And what you mentioned there was, just on the last point, what you mentioned there was is very true. The patients who have wear on their teeth, they often don't have stresses on their masticatory system. With those patients whose periodontium has taken all the stresses, they often don't have the wear. The opposite in a way, right? So sometimes patients have lots of wear but no jaw issues. Sometimes patients have mobility in their teeth but no wear, and so this is all part of like the weakest link theory. That is a really good paper I'll attach to his episode. It's like trying to put patients into boxes. It's just like a stupid little thing to do, but it kind of explains what we see in the real world. Hans, thank you so much for this. Please do tell us about any education you run. I know you're on the lecture circuit. If you've got any education coming up that you'd like our audience to tune into, I'd love for you to talk about that, my friend.
Usually I lecture in Norwegian mostly, at least for now. Perhaps this will change after this podcast. You have a very widespread audience around the world. At the moment, I do not have anything coming up. I'm very involved with building a new clinic, so that's mostly what's on my mind, and we'll see what opportunities comes later on. Other than that, if you want to see me, I do run the continuing education with 4 fellows of mine here in Stavanger, here in this part of the country, so you can come see some of our courses if you like. We have some quite interesting ones.
And your Instagram handle, so they can see your lovely photography. And
it's Tannlege Ognedal, so it's in Norwegian. My last name, and tannlege, which is dentist in Norwegian. So that's my Instagram handle, and you're free to share that, of course, on your videos.
Amazing. No, I always tag our guests in the description. So Hans, thank you so much.
Thanks. If anyone has a question, I'm really happy to answer them. Send me a message on Instagram. I think that's easiest. No worries.
And send Hans a message on Insta or comment below, and I'll tell Hans now and again, check it, and to hopefully see lots of thank yous. And thanks for covering, honestly, Hans, thank you for covering a topic that is not widely talked about, and is a really good minimally invasive solution when we're scratching our head, running out of ideas, because classically, yes, gold onlays or these ways of doing it, but to raise the vertical dimension on posteriors only can be a very scary thing to do when you're, let alone doing anterior Dahl for the first time, to do this reverse Dahl. And I think you've just covered it really well in a really pragmatic way. I like that it's not very, you're not using wax ups, you're not using funky stuff, you're just building them up to anatomical form, and you're letting nature do the rest.
Yeah, and but of course, scanning has worked wonders. You asked about injection molding at one point. Why not? But then you already has involved some very heavy technology so you can manage the occlusion in a whole nother way. This technique, the reverse Dahl, really started as a really hands-on direct composite way to do it, just to minimize the expenses of having models, having wax ups, doing difficult occlusal stuff.
Appreciate your time, and thanks so much for everyone for listening to the end. Well, there we have it, guys. Thanks so much for listening all the way to the end. Now you know about the reverse Dahl technique. If you're inspired by this and you want to learn more about the normal Dahl technique, then again, I've linked it all in the show notes. This episode is eligible for an hour of CPD or CE credits. We are a PACE approved provider. Now that you've done the hard work of listening to someone talk about teeth for a whole hour, just answer the questions, get 80%, and you get your CE certificate. Our CPD queen, Marie, will look after you. And just like this, you can gain so many hours throughout the year, making this one of the most valuable subscriptions that you have. So if you're interested in joining us and joining the nicest and geekiest dentists in the world, check out Protrusive Guidance. It's an app on iOS or Android, but the best way to sign up is on the laptop first. Go to protrusive.app. Sign up to your level of subscription. If you go for the ultimate, you get all my masterclasses as well, including my premium clinical videos. I want to thank you again for listening. I want to thank the team of Erica, Jan, Chriselle, Julia, Nav, Emma, who at this moment in time is doing her finals, so wishing her all the best. And with that, my friends, thank you so much. I'll catch you same time, same place next week. Bye for now. Oh, and don't forget to give this a thumbs up.